Chapter 39 is entitled Nursing Care of the Child Born with a Physical Developmental Disorder, and there are a couple different disorders that we're going to cover from this chapter. Those are listed on your slide: cleft lip and cleft palate, tracheoesophageal atresia and fistula, neurotube defects, hydrocephalus, Telpe's deformities, and developmental hip dysplasia. The first to talk about is cleft lip and cleft palate. As you can see on the slide here, just a few comparisons between the two. You'll see with both of them, they occur very early in gestation, within that first trimester. Cleft lip a little bit earlier than cleft palate. You can see the incidence of boys and girls. Boys having a little bit higher incidence of cleft lip, while girls having a little bit higher incidence of cleft palate. The incidence in general with births, cleft lip being a little more common, 1 in 700 births, versus cleft palate, 1 out of 2,000 births. However, if you look under cleft palate, if it's occurring with cleft lip, it falls kind of in the middle there, 1 out of about 1,000 births. There is a picture in the OB section of your textbook on page 166 of a child with a cleft lip, so that you can look at that as well. On the external links page on Blackboard, there is also a website that will take you to Smile Train, which is an organization that assists children outside of the United States in getting cleft lip and cleft palate surgery. So you may want to look at that site as well. There are some pictures there as well with the kids. Cleft lip and cleft palate can take on a variety of different forms, in that the cleft lip, it may just be unilateral or on one side of the lip, or it may be bilateral where it's on both sides of the lip. It may be complete or incomplete. In other words, it may extend up into the nasal passageways, being complete, or incomplete where it doesn't go that far. With the cleft palate, it could just be the hard palate that's affected. It could be the hard and the soft palate. Again, it could be unilateral or bilateral. So lots of variations on how that can occur. Some other information: both of these can be detected on ultrasound. Both of them can be repaired surgically with a very good prognosis. The big difference in the repair is when that repair is occurring. Usually with cleft lip, it's occurring fairly early in life, versus with cleft palate, it may be a little bit later. Cleft lip, we're thinking maybe around a month or so of age, whereas cleft palate, child may be getting closer to that first birthday before they would have that surgical repair. You do have a picture in your textbook on page 1185 showing a child who had a surgical repair of a cleft lip. And again, other than maybe a very, very faint looking scar in that picture, it may just be the quality of the picture, you certainly would never imagine that child had been born with any type of cleft lip. Just a note also on the slide here that says cleft palate can be a component of many syndromes and to look for other anomalies. That's probably true in general in pediatrics. If we see a child that's born with a particular anomaly, oftentimes we may need to look for 2 or 3 other symptoms or other disorders perhaps. I'm going to go back to the other slide just to say a few other things related to cleft lip and cleft palate. In your textbook, you have a nice care plan, outlined nursing diagnoses, starting on page 1186, and that continues on through page 1189, talking about some of the issues that children with cleft lip and cleft palate deal with. Certainly nutrition is one of the big issues. Feeding can be a problem with cleft lip or cleft palate. So again, if you look on page 1186 in your textbook, you'll see you've got some pictures there of different feeding devices. They talk about the importance of small, frequent feedings, of burping or bubbling the baby frequently during those feeds because they do tend to swallow a lot of air. Keeping the child in an upright position is very important. Some of the issues post-operatively too, just think about positioning. When we had a child who just had a cleft lip repair, we do not want to place them on their bellies, because what may happen, they may be able to rub their face on the mattress and harm that surgical site. On page 1187, you can see there's a picture of what's called a Logan bar. Again, this kind of helps to keep pressure or tension off of that suture site, which is very important. As the child starts resuming feedings following the cleft lip surgery, again, the importance of washing and keeping that incision site clear. One of the other issues to think about post-operatively for a child who's had a cleft lip or cleft palate repair is that they oftentimes, their natural response is going to be to get their fingers up to their mouth or where that surgical site is. So elbow restraints may be appropriate as well, so that they're not harming that. Again, going back to keeping the tension off of the suture line with the cleft lip, we don't want them crying for excessive periods of time. One thing that's important following cleft palate repair is not using a spoon, because putting a spoon in the child's mouth, again, may cause trauma to that surgical site. A straw, although it's probably likely that a child that young having a cleft palate repair wouldn't be using a straw, but certainly that wouldn't be appropriate as well. And even just the child playing with toys, we want to make sure it's nothing that they're going to stick in their mouth that may cause harm to that site. But again, I'd encourage you to review those nursing diagnoses and interventions included in Pilotary related to cleft lip and cleft palate. The next topic, tracheoesophageal atresia and fistula, is included also in this chapter. This also, just like cleft lip and cleft palate, occurs early on in gestation, 4 to 8 weeks. So again, it may be occurring before a woman would even know that she was pregnant. The incidence is about 1 in 3,000 live births. Again, maybe a little more common in premature births. Must be ruled out if mother has hydramnios. And just to speak to this a little bit, I'm not sure how many of you have had OB before taking this course. If you have or haven't, just to kind of review this, hydramnios is an excessive amount of amniotic fluid that a mom may be detected to have during her pregnancy. Another term they use sometimes is polyhydramnios. In utero, the fetus will swallow amniotic fluid. A child who has esophageal atresia cannot swallow that amniotic fluid, thus we may see an increase in the amount of amniotic fluid that mom has. There can be other reasons for hydramnios to develop, so I don't want you to automatically think when you're in OB and you see a diagnosis of hydramnios that the child must have this condition. They would certainly rule it out, but just again something to think about. If you look on page 1190 in your textbook, you have a good outline of what the different variations that this particular anomaly can take. Again, atresia means something that's kind of not fully developed. So when we're talking about esophageal atresia, especially if you're looking at letters A and letter B, you'll see that that upper portion of the esophagus is just kind of ending in a blind pouch. It's not connected to the stomach. We know that fistula means opening. So when we have a child with a tracheoesophageal fistula, we know that we have a connection or an opening between the trachea and the esophagus. And again, if you look at letter A, you can see where that connection from the lower portion of the esophagus coming off of the stomach is connected directly to the trachea. Also, as it says on the slide here, this may accompany a variety of other congenital anomalies. Some of those are addressed in the reading as well. As we're looking at those pictures again on page 1190, the picture, or letter A, is probably the most common variation. So as we're talking about that, you can kind of keep in mind, if that's how the anatomy looks, what's going to happen with the child? This slide again just kind of shows you that opening, or that fistula between the two, and then obviously following a repair, which you've probably guessed by now, this definitely has to be repaired surgically. What are some of those first signs and symptoms that we may notice with a child who has esophageal atresia or a tracheoesophageal fistula, sometimes abbreviated TEF? We'll see a lot of coughing and choking and emesis with their first feedings, lots of fluids coming through the nose and mouth. And if you think about it, look at how that esophagus is formed, or maybe not formed. It just ends in that blind pouch. So if we're feeding a child, food entering their esophagus, it has nowhere to go but just to come right back out. So we're going to see a lot of that spitting and sputtering, so to speak, with that first feeding. Excessive salivation and drooling. The child's not going to be able to handle their oral secretions and kind of the blowing bubbles. We're going to start to see some respiratory involvement as well. We have the risk of aspiration pneumonia because we have stomach secretions that have a direct connection right up into the respiratory tract, into the trachea. So again, hopefully as you're looking at that picture, you see that this is something that becomes a surgical emergency. We need to do something about this fairly quickly. Prior to going to surgery, what are some things we can do? Well, keep the child in an upright position. Let gravity work with us instead of against us to prevent aspiration. Maintaining body heat is always important, again, especially dealing with a newborn. Decreasing crying becomes important because as the child cries, that's probably going to cause the stomach to become distended. Again, we may be increasing the likelihood of aspiration. A pacifier for sucking needs, sometimes they refer to that as non-nutritive sucking. A child, that's an infant's natural response, that sucking reflex. If that can't be met through oral feedings, which obviously this child is going to be NPO, providing a pacifier is important. And again, they will take the child to surgery. The first thing that they're probably going to do is try to close off that fistula and place a G-tube. Initially, that G-tube will be used to empty the stomach until we can get that fistula closed. Once the fistula is closed, then they will go ahead and try to repair the esophagus, where they'll kind of reanastomose the ends back together. And again, on page 1190, you have a description of the surgical procedure as well. But again, it's not uncommon to see them place a G-tube initially for emptying of stomach contents. After that fistula is closed and the esophagus is repaired, they may use that G-tube for feeding while the esophagus heals. It's likely the child won't have to have that G-tube for life, assuming the surgery was successful. But again, we would never use that G-tube to feed a child until that fistula was closed. And again, you have a nice outline of some nursing diagnoses for a child with this, starting on page 1190 and continuing on to page 1191. Neural tube defects is the next thing that I'd like to cover from your textbook. There are a couple things that fall under that heading of neural tube defects. The first is anencephaly. You have a picture in your textbook on page 1206 of an infant who was born with anencephaly. Basically, with anencephaly, this is a condition that is incompatible with life. There's pretty much an absence of much in terms of the brain structure. And again, a child born with anencephaly is probably not going to survive much past maybe a few minutes, a few hours after delivery. Some perhaps may even be stillborn. Microcephaly Microcephaly is when we have brain growth that is very slow and less than what we would typically expect for a child. There can be varying degrees of microcephaly. It's likely that a child with microcephaly is going to have some cognitive delays and probably a variety of health issues that they will be dealing with. And then the last of the neural tube defects, which I want to spend a little more time on, is spina bifida. And again, we can kind of think of spina bifida as being kind of an umbrella term, and then the different types of spina bifida are listed there. Spina bifida occulta, a meningeocele, and then a myelomeningeocele. You have pictures in your textbook on the bottom of page 1206 that kind of outline the differences between these. And again, you can think about these as increasing in severity as we go down the list. This picture again just is kind of similar to it. It's actually showing a myelomeningeocele with the picture on the left. And then typically where it may be located on the child, on the back area, oftentimes down in that lumbar sacral area. Spina bifida occulta. With that, again, this picture kind of shows you, and you have a similar picture in your textbook on page 1206, you'll see that some of the vertebrae haven't completely fused and you've got a bit of a gap. The spinal cord itself is still intact. The only thing outwardly that you may see with a child with spina bifida occulta, or an adult, would be maybe a depression or a dimpling in the lower back area, and then over that area you may see a patch of kind of really coarse like hair. It's likely that individuals with spina bifida occulta may never even know that they have this going on. I had a student a couple semesters ago tell me that she had been in a car accident in her early 20s and had had some injuries, so had had a lot of testing done, x-rays, CTs, MRIs, those types of things. And they actually told her that she had spina bifida occulta, but again, never really had any clinical symptoms with this particular disorder. So most people with spina bifida occulta will, live a normal life with very minimal to no clinical implications. Now as we start kind of moving up the ladder a little bit here with a meningeocele. Now you can see again kind of the same thing that with the spina bifida occulta, where there's kind of that gap there between the vertebrae. But with a meningeocele, now what's happened is we have a protrusion through that opening, a sac-like protrusion that contains cerebral spinal fluid. Now from the picture here, again, you can see the spinal cord is basically intact. So once that sac has been taken care of and closed, it's likely that the child will not have many clinical symptoms because hopefully we haven't had any damage to that spinal column, or spinal cord, I should say, itself. Kind of the worst case scenario with spina bifida is the myelomeningeocele. I use that term worst case scenario in that this is the one that will have the major clinical implications for the child. Again, you can see how we've taken it one step further from the previous slide. Now in that sac-like protrusion, it's not only filled with cerebral spinal fluid, but it has a portion of the spinal cord and nerve endings as well included in that. We don't really know why a child is born with spina bifida. There's thoughts that there are some genetic links, perhaps some environmental influences. The one thing that we do know related to to neural tube defects is that a woman ingesting folic acid prior to pregnancy will greatly decrease the chance of having a baby born with a neural tube defect. The recommendation right now is 0.4 milligrams of folic acid daily. And in order for that to be effective, a woman needs to have been taking that folic acid for at least 3 months prior to becoming pregnant, because this is a disorder that occurs very early in gestation, just like the other two that we've talked about from this chapter. So in order for it to be most effective, that woman has to have been taking that folic acid at least 3 months prior to pregnancy. Just to talk about, again, now focusing on myelomeningocele. The child's going to have surgery very soon after birth. On the slide it says 24 to 48 hours. My experience has always been the child has been in surgery for repair within 24 hours of birth. Why the rush to surgery? We want to decrease the likelihood of infection. When we have this sac on the child's back, it's not always completely skin covered. Sometimes it may just be kind of a membrane type covering. So it's very important that we get the child to surgery to close that area off so that we minimize the risk for infection, because if that area gets infection, that's like a direct connection right into the central nervous system. Prior to going to surgery, protecting that sac becomes very important. Covering it with moist, sterile dressings, keeping the infant laying on their belly with pressure off of that site is important. Prognosis depends a lot on the level of the lesion. On page 1207, you have, in other words, where the lesion is located and then what might be the resulting clinical effects. We could probably line up 10 kids who were born with a myelomeningocele and find 10 different ways in which they are affected. Some may be ambulatory, some may walk with assistive devices, others may be completely confined to a wheelchair. Probably one of the things we would find common across the board, they all have problems with bowel and bladder dysfunction. Hydrocephalus is very common. I would guess probably more than 90% of kids born with a myelomeningocele may have some degree of hydrocephalus. And again, thinking about the bowel and bladder innervation, if you look at innervation down the spine, for the bowel and bladder it's fairly low. So wherever that lesion is, think about innervation going down that spine. Wherever that lesion is, from there on down is going to be affected. Long-term follow-up care, again, you have some nice nursing diagnoses listed starting on page 1208 and continuing through page 1210. So you can review that as well. Once we get the child through surgery, again, a lot of it then is promoting physical mobility following that. If they need to work with physical therapy or occupational therapy. I said there is the high risk of hydrocephalus or a high incidence of hydrocephalus occurring with children with myelomeningocele, so that's another issue, and we'll talk a little bit more about that in just a minute. One other thing just to mention about children with spina bifida. There is a very high rate of latex allergies in those individuals who have been born with spina bifida. So high that now it's just kind of assumed. When a child is born with spina bifida, they automatically are given that latex allergy. So we would not use any latex products around them. Some children, it's a very mild allergy, contact with latex. It may just be, the skin gets a little irritated. There are other documented cases of children coming in contact with latex and going into full-blown anaphylactic reaction, and actually some have died from that. So that's one thing to keep in mind also with spina bifida. And I'm not sure that that's something that's designated specifically in your textbook, so I kind of just wanted to add that in there. Again, these are just some of the areas. I've kind of already addressed these with nursing care, and those are addressed in that those plan of care on pages 1208 through 1210 in your textbook. Okay, now some information on hydrocephalus, which in your textbook this information starts on page 1198. As you can see on the slide there, it's an excessive accumulation of CSF fluid in the ventricular spaces of the brain. The incidence 3 to 4 per 1,000 live births. Again, if we look at specific populations, again thinking about that patient of, or that segment of the population born with a myelomeningocele, the incidence would be significantly higher with that. Again, if we're thinking neural tube defect, with those ventricles being a part of that central nervous system. With hydrocephalus, we are going to see signs of increased intracranial pressure. You have on page 1199 a picture of an infant, and they give you some data that you would find as far as an assessment of an infant with hydrocephalus, so I would encourage you to take a look at that. This picture here, again, just another picture that kind of shows you the enlarged ventricles with the fluid accumulation. But again, thinking about signs and symptoms found in infants and children. Infants may try to accommodate for some of those increasing size in the ventricles, again because their scalp is not has not fused completely. They have those open fontanelles, so their skull can expand slightly to try to accommodate for that. We may see increasing head circumference. Again, when we're thinking back to our care for a child with a myelomeningocele, the one thing we'd want to keep checking is their head circumference to see, are we picking up any increases. The prominent scalp veins, or the sunset eyes, where their eyes, if we're looking at them, thinking about the iris or the colored part of their eyes is the sun, and that's just kind of drifting downwards, or like the sun is setting, that's kind of what that's referring to. The fontanelles, especially that anterior fontanelle, may appear much bigger than we would typically expect, the skin over it appearing very tense, or it may even be bulging. Irritability, lethargy, sometimes also we think about that shrill or high-pitched cry. Failure to thrive, the child may not be eating well or may have some vomiting as well. And again, feeling the child's head, we may notice some of those separated suture lines. In children, again, signs of that increased intracranial pressure. Some of the first signs we might see is a headache, change in level of consciousness, some confusion. With hydrocephalus, it's important to pick it up early and manage it so that we can minimize the likelihood that we have any brain damage occurring. Typically, with hydrocephalus, it is managed through the insertion of a ventriculoperitoneal shunt. A shunt that's inserted from the ventricles down to the peritoneal cavity that kind of has a one-way valve on it. So as fluid builds up in the ventricle, it triggers that valve to open and shuts that fluid down into the peritoneal cavity, where it then just can be absorbed by the body. Pre- and post-op care are included in that care plan you have starting on page 1200 and continuing through page 1205, so you can review that in your textbook. Some complications that can occur when we put in a VP shunt. And one thing to say, sometimes students will ask, well, does a child have that shunt for life? In most instances, I would say that's probably true. I have seen some cases where a child has, the shunt has maybe stopped working, but they haven't had any signs, any problems since then, and they've never had to have that shunt reinserted. But probably in most cases, once a child has a shunt, they're going to have it most likely for life. What can be some complications? It is a foreign material in the body, so infection. When they get infected, again, the child may need to be in the hospital, may have to go to surgery for revision of that shunt, involving antibiotics, all those types of things. The shunt may stop working. How do we know it's not working? Well, we're probably going to start seeing some signs of increased intracranial pressure. The other issue becomes just accommodating for the child's growth. If we diagnose a child at 2 months of age with hydrocephalus and they insert a VP shunt, they can put in some extra, but not likely to be enough that will hold them until they're, into school age and adolescence. So they may have to go in for revisions of that as well. This picture here, again, just similar to the one in your textbook with that VP shunt. This picture also makes the comment, it says in some cases tubing may lead to the heart. That was kind of that is no longer done. They used to have VA shunts, were ventricular atrial shunts, but they don't do those anymore. It's just strictly the VP shunts. And when VP shunts kind of came on the market or were discovered, it really changed the face of hydrocephalus in terms of, prior to that time you had children with hydrocephalus being severely mentally retarded, probably not living very productive lives, quality of life was very limited. Now that we have this in place, we have children who are just, growing by leaps and bounds and having a much better quality of life than they had had prior to those VP shunts. Telpe's deformities, or maybe what you would be more familiar with would be the term club foot. As you can see from the reading in your textbook, they are trying to get away from that terminology of saying club foot. It kind of has maybe a negative connotation. Incidence with Telpe's deformities, 1 to 2 out of every 1,000 births. This is one where boys are significantly more affected than girls. The earlier the treatment, the better the correction. So again, we usually can diagnose this at birth or shortly thereafter. They will want to start correction very early, definitely before the child would get to the age where they would be walking. I have 3 nursing diagnoses listed here that would certainly apply to a child who is has been diagnosed with a Telpe's deformity and is undergoing treatment. Impaired physical mobility related to the casts. If you look on page 1214 in your textbook, you'll see that the casting is usually the desired treatment or the treatment of choice for a Telpe's deformity. And you will see that they will put the feet in an over-corrected position. So again, if you look at letter A or the picture on page 1214 where the feet are kind of turned inward, then when we're correcting them, they are kind of turned outward, and that is the desired position for correction. You can also see that those casts extend up into the thigh area. So that kind of leads us into our next issue with risk for impaired skin integrity. We want to, those casts are getting very close to the diaper area, so we want to make sure that they're not getting soiled from urine or stool. The other thing is that these casts may stay on for several weeks, even getting into the 2-month range or so. A child in infancy is growing very quickly. Birth to a year of age is the most rapid time of growth. So casts that are put on at 2 weeks of age may get too tight by the time the child is 4 weeks of age, or some variation of that time frame. So they may be changing the casts every few weeks. Knowledge deficit, again, teaching with the parents is very important in terms of handling the casts, how to determine if they're too tight, what's the treatment plan, what are our follow-ups going to be following when the casts come off. All of that information important to give the parents. Next is developmental hip dysplasia. Again, this is something that is much more common in girls. 6 times more likely to occur in girls than boys. Signs and symptoms. On page 1215 you can see at the figure 3919 they give you some examples. One leg may appear longer than the other. We may see those asymmetrical Gluteal folds, you know, the cute little rolls and creases that infants have on their legs, if we see them being asymmetrical. Treatment options. This is another condition that we want to diagnose and treat early, because if it's left untreated as the child starts growing and would start walking, we could then have permanent changes as far as uneven leg lengths, a lot of hip and mobility issues. So they will screen all children for this. You'll see them doing that in the newborn nursery. If you haven't been there already, you'll probably see them doing that. They'll have the baby laying on the table, flex their legs up onto their belly, and then they're abducting their legs, or taking them away from the body. Normally, we should be able to abduct those legs, kind of each of them 90 degrees, so they'd be laying flat on the table. If a child has hip dysplasia, we're going to have limited abduction on that side. Our treatment, this picture right here just again kind of shows you what's happening there, where that head of the femur is kind of moving out of that acetabulum as it's becoming dislocated. And again, some of the signs and symptoms there. Treatment, you know, with the Talpe's deformities, we talked about having those feet in an overcorrected position. The desired position for a child being treated for developmental hip dysplasia is in a flexed and abducted position. If you look at your textbook on page 1217, you can see 3 pictures of children using 3 different devices for treatment of hip dysplasia. But we need to have them in that flexed and abducted position because we need to deepen the contour of that head of the femur into the acetabulum so it does not become displaced. One thing that's not mentioned here that sometimes may be used initially, depending on the degree of involvement, might be double or triple diapering. And again, just think about if you had a baby laying in front of you and I gave you 3 diapers and told you to put, again, if you're thinking about putting all 3 of those diapers on the infant at the same time, by the time you're getting that 3rd diaper on, you can imagine what's happening to the child's legs. They're getting in that flexed and abducted position. And again, that picture on page 1217 kind of shows you the FRICA splint in letter A. Probably more often used is in letter B there with the Pavlik harness. The one thing with these harnesses is that they stay on pretty much 24 hours a day. Parents may be allowed to remove them for bathing, although some physicians may just tell them to sponge bathe the child. Or we may even get to casting, as they show in letter C there, for correction as well. And again, this is something that's going to go on for a significant period of time in which the child may be growing. So if we are dealing with casts here, it would be important to monitor for signs and symptoms that the cast is too tight. And just to refer you also back to page 1216 with the Ortolani's and Barlow sign, and that's a demonstration, kind of what I was trying to describe to you as far as flexing the child's legs up and then abducting them as well to see how much range of motion that